Hello and welcome to week 8 of Ethics. It's Jacqueline Lamoche speaking to you. I hope you had a good reading week, and I hope that you had a good week of reflection and time to really think about how you'd like to move forward in the remainder of our course. This is a very challenging set of ideas that we need to consider this week. This week we're discussing the Canadian Nurses Association Code of Ethics Value Statement number 3, which is about promoting and respecting informed decision-making. I think that we make a lot of assumptions around autonomy and around an individual's right to decide. As Canadians, we live in a democracy and we think that we have free will and we think that we have the ability to decide what happens to our own body. And while we've come a long way in that regard, I think if we look at some of the micro decisions that are made, all the way up to some of the bigger decisions, we might actually see that autonomy is not as taken for granted as we might hope. Therefore, this week we really look at terms such as self-determination, autonomy, choice, and informed consent. And we really consider what practices from nurses and from the healthcare system as a whole both promote and limit an individual's choice and an individual's ability to decide what happens to his or her body. We'll also have an opportunity through the forum discussions to examine some of the articles around provided to us by Aveyard and Bingham. It's also important in this week that we consider some of the laws and some of the structures that support a person's right to decide, and that also lay out for us the consequences should we overstep. Lastly, and you'll see it separated out from the list of things that we're doing, is an independent activity if you're interested. In the course documents for this week, you'll see an internet search activity that you can really begin to explore for yourself some of the ideas around consent and informed decision making. So this value statement, number 3, is about promoting and respecting informed decision-making. And part of the nurse's responsibilities within this value statement is to recognize, respect, and promote a person's right to be informed and to make decisions. So in order to fulfill this responsibility, we need to first be able to recognize when autonomy is an issue. It's to be able to challenge some of the taken for granted practices that perhaps limit a person's autonomy. To fulfill this practice, we also have to recognize when power relations or when some of the hierarchies that are inherent in the nurse-patient relationship are activated and actually limit a person's ability to decide what happens to his or her own body. It also requires us to decide if autonomy is a reasonable goal. We have many situations where one person's autonomy would infringe on the autonomy of another, and so these become very difficult situations. We also need to recognize how a person's autonomy influences us individually and collectively as a profession. Sometimes instances of autonomy, when a patient is exerting those decisions, it actually creates quite a bit of tension and moral distress for nurses. So we need to find ways to think about and to reconcile some of these tensions. This requires us, in turn, to understand the limits of autonomy and when those limits are reached and what happens. We do live within a system that has laws and that has regulation, and there are limits to what people can decide for themselves, and there are also situations, for example, in situations of incapacity, where a person cannot make his or her own decisions, and somebody needs to be substituted or come in and make decisions for them. So we need to examine the processes in that situation as well. So we haven't been together for a couple of weeks because we had a week of reflection and we had reading week. So just in case you've forgotten in the intervening weeks, ethics courses tend to ask more questions than they answer. So I thought it was fitting that we begin part of our discussion with a series of provocative questions. So pause the PowerPoint presentation and consider your answers and your views on some of these. Have you ever wondered about your patient's ability to give consent? How do you ask for permission or consent for your care? For example, you might have been in practicum this week, and how did you actually ask for a person's permission or consent? Have you helped someone decide and or give consent? Nurses are often asked for their opinion, for their expert knowledge, for their counsel. Has this happened to you, and how did you go about providing that assistance? How do we as nurses help someone to make the best decision? And lastly, who decides really about what is best? What have you noticed already in practice, especially with nursing care? For example, a patient's decision to get out of bed and have a shower. What happens when somebody actually doesn't want to do this? How many times do we ask the same question? How many times do we use patient education as a means of coercion or a means of trying to bring somebody in line with our wishes? So these questions are important for us to consider in terms of reflecting on our practice and how we're actually living out this value statement, and what it means to us as nurses to really give the authority to the patient to make decisions. The previous slide had a series of questions that were aimed at prompting you to think about your nursing practice. This question is asking you to think about your personal life, your own individual situation, and your own autonomy. What are the limits on your autonomy? What constrains you? What promotes you to make your own decision? When you're making decisions, what else are you thinking about? So really what I'm getting at here in these questions is for us to really begin to understand the complexity of autonomy. It isn't taken for granted. There are many institutionalized practices, there are many professional practices, and there are many ruling relations and power relations that give even the competent adult a challenge to make his or her own decisions. And then when we start bringing in vulnerable populations, for example, children or people who are cognitively impaired, how do they make decisions and how do they give consent? I'm thinking about the story in your textbook, Mary, the pregnant woman with severe depression for whom ECT had been recommended. She has to decide both for herself and for her baby. And we recognize that autonomy is often relative and relational. So what can the philosophers contribute to our understanding of autonomy and to being able to really explore how autonomy is both honored and dismissed in the everyday nursing practice? Let's take first Kant. Kant offers the categorical imperative, which is to treat people as an end and never as a means only. So if we're treating people as an end in and of themselves and not as a means to an end, I think it changes our attitude and our decisions about everyday practices. For example, the way that we try to impose nursing routines on patients. One of the other suggestions by Kant that is useful to me is that people must always be treated with respect and dignity, and recognizing that people have the ability to reason. This means that people have the ability to understand and to make their own decisions, and that the decisions that they make must be treated with respect, and that sometimes patients will make decisions that are not necessarily ones that we would make, but at the same time we need to treat those people with dignity and still respect their decisions. Mill, on the other hand, his ideas about the greatest good for the greatest number helps us to understand decision-making in that view as well. So Mill suggests that we can make decisions for ourselves, but only insofar as they do not affect the welfare of others. And this is really complex because it's hard to think that any of us can make a decision that doesn't have some impact on somebody else. However, Mill suggests that our decisions are limited by the effects that they have on others, so it's the degree to effect, and that others can be allowed to decide only if they have the capacity to do so. So Mill is recognizing that there are instances that perhaps people cannot make their own decisions. So as with my statements that I'm about to make on feminist ethics, so too do the ideas that I presented in a very brief way about Kant and John Stuart Mill. They need to be fleshed out by your reading and by your thinking. These are just a few introductory comments. I do, however, find the work of feminist ethics quite useful to my considerations of autonomy. The feminist ethicists introduce this notion of relational autonomy. This begins to recognize that we have autonomy in relation to other people. So let's take it, for instance, a mother who makes decisions. She needs to consider how her decisions will influence her children. So in this way, her autonomy is restricted. She can't just make a decision for herself because she recognizes that her decisions impact on others. So the feminist ethics asks us to think about autonomy as more than an individual's right to make a decision. I've included here a quote from Burgum and Dossiter from your textbook. In practice, we see how autonomy is lived in relation to others. Lived autonomy is found in personal connections to others and responsibilities. So responsibility and connectedness to others cannot be separated from decision making. And I like this quote because it speaks to the fact that autonomy is not static, that it is dynamic, and it speaks to the complexity and to the fact that we're constantly making micro decisions and macro decisions, considering their consequences. So I find this an interesting idea and way to look at autonomy, in particular vis-a-vis the statements that I made earlier from John Stuart Mill. So regardless of which ethics theory, framework, or approach, we see that autonomy is a central theme to ethical decision making. Respecting a person's freedom to choose is at the heart of an ethical practice. However, we know that there are limits to autonomy. We can take the overused example of somebody wishing to commit suicide. On one hand, if we truly had autonomy, we would be able to make our own decisions and end our life when we see fit. However, the law has come in and set out a guide or an actual restriction in that committing suicide is actually against the law. And in terms of healthcare practice, it is still against the law for us to practice euthanasia or even to participate in assisted suicide. So the law provides a lot of structure around what is permitted and what is not permitted. The law also protects an individual's autonomy in that we can't, as health professionals, overstep. So as regulated health professionals, the College of Nurses has a lot of standards of practice that limit our ability to make decisions for others and lay out the consequences should we overstep those boundaries. So this slide is just trying to show you the notions and practices that surround autonomy, and that it is highly complex, and that it is relative and relational, and that there are both constraints and societal practices that promote autonomy. So this slide is an overview slide of what we'll be considering in the next few moments together. So what these circles represent are the various aspects of our society and our way of thinking about decision making and our way of considering healthcare practices, including some of the laws and some of the regulations that influence our practice. And they're all the ideas that sort of circle around and influence decision making. So as I mentioned earlier, we have laws and regulations that protect a person's autonomy, and one of those is informed consent. So as you know now, as fourth semester students, prior to having surgery or a procedure, patients must give consent for that procedure. And we've challenged a little bit the notion about how many times do we overstep a person's decision. And we see that sometimes when we go in to do personal care, we see that sometimes when we go in to take vital signs, the way that we encourage people to eat or drink, to walk after surgery, to deep breathe or cough. But what is really good about informed consent and some of the laws that surround that is that it really does reduce paternalism. These laws set out fairly rigorous standards and guidelines for us to understand who gets to decide. It also can be difficult because sometimes informed consent puts a decision in the hands of somebody who really may be ill-prepared to make that decision. And we sometimes see patients really struggling with those decisions, whether they should have another round of chemotherapy, whether they should take this exploratory surgery. Sometimes it can be very difficult for patients to make those decisions on their own. But ultimately, our laws and our practices around informed consent allow a person for some control over what happens to him or her, and ideally all of the control. So there are many supports for you to be considering autonomy and ethical decision making, and to ensure that your practice is actually fulfilling the value statements and the standards of practice and practice within our legal system. The ethics composite model on page 46 of your textbook is quite useful, and there's a great explanation found on page 150 that can show you how you use that model for decision making. Our understanding remains the same. The more and different ways we have for exploring a situation, the more fully we can understand it. As with all ethical decision making and ethical explorations, we need to be able to dig deep. We need to be able to really explore the situation from a variety of perspectives. And as we use different ethics theories, that analysis expands our understanding. So we know that when we use decision-making models, for example, the Storch model, the Oberle-Raffenbuchel model, the Thompson model, or perhaps a model that you've located and are finding particularly useful, it brings us through our thinking in a very systematic way and calls upon us to look at the situation from many perspectives to ensure that in fact our practice is aligning with ethics and the ethical standards. So inherent in the decision-making models that we've been discussing is this notion that we need to speak to our patients and we need to understand what is of concern to them and what is influencing their ability to make decisions, and what are their concerns in terms of the outcomes of the decisions that they make. So this speaks to the fact that as nurses, we need to have relational skills. And so at this time I would ask, if as a nurse you're meant to support autonomy for a patient and to promote their ability to make their own decisions, what skills do you need to strengthen to be able to support patients and families in making autonomous choices? I think it's also important to think about the notion of, do people have the right not to choose? Or that people can receive too much information. So when we're thinking of the notion of informed consent, sometimes people can be overwhelmed with information. And in fact, when we consider the role of patient education that we did before the break, we can recognize that we sometimes use patient education as a strategy for coercion. So that's very, very complex in how we relate to a person to support their decisions. So choice really is a value that we need to live. And I like this idea of considering autonomy and decision-making as something that is fluid and evolving. I think we've all been part of an experience where we've made decisions, and when the full outcomes, or when some of the outcomes of those decisions start to manifest, we change our minds. And I think that that's important for us to remember that when we're working with patients, and to recognize that patients will also change their minds, and that that is perfectly okay and should be encouraged. So the whole idea of decision-making and autonomy and consent is a living, breathing phenomena. So here's the little model that that I've organized the class around. So we've been talking about autonomy and relational autonomy and the practice around consent that is both a moral obligation, an ethical obligation, but also a legal obligation. We've been talking about some of the power inherent in the practices that surround autonomy and decision-making. I think that some of Aristotle's work around the virtues, in particular the virtues of honesty and truth-telling, are really key. And to really be able to examine our own practice in terms of how are we giving and withholding information? Are we really doing that as a means to an end or as an end in and of itself? And Kant's work can be quite useful in that. So some of the work that we're going to be doing as we move through the class is really looking at choice and really looking at some of the ideas around voluntariness, capacity to make decisions, a person's ability to comprehend, and when a person is not able to make their own decisions, what are some of the practices, for example, substitute decision making, that can support a person's will. I put some of these resources here really just to remind me to tell you that the laws are constantly changing and evolving around who can decide and under what conditions and what needs to happen in terms of substitute decision makers. So I'm presenting to you what I understand to be correct at this time, but for you to be aware that a process of lifelong learning is really important in this area, because in my time of being a nurse there have been several changes, and keeping up to date with these is quite important. Okay, so let's get into some of the nitty-gritty about autonomy. So within Canada, under the Charter of Rights and Freedoms, we do have the right to make our own decisions, but we also have to have the ability to make meaningful choices. And there are times, and for certain individuals, that they don't have the ability to make their own decisions. Either they're so severely cognitively impaired, or they're in a coma, or there's some other situation around that. So autonomy really is the foundation principle of ethics, and there are 4 components to autonomy that we need to consider. So at the core of autonomy is this notion of self-determination, that as individuals, we get to decide what happens to our personhood, to our body, to our health experience. We also have to have the freedom to practice our autonomy, and we have to be able to do this without coercion. And in fact, I think it's this freedom that is perhaps the area that is the most fruitful in our exploration. There are many professional practices and many institutional practices that have perhaps an unintended consequence of exerting coercion on patients and thus limiting their autonomy. For people to have autonomy, they have to have a sense of a goal. They have to have a sense that they're trying to fulfill their desire. And lastly, they have to have independence. This is highly linked to capacity, and it's the ability to do things for ourselves. So there are also 3 dimensions of informed consent. So the first is this idea of voluntariness. So we can see that it's speaking to the component of freedom. So it's without coercion or inducement. So we can't threaten that there would be a good or a bad outcome or put any kind of pressure. So when we're obtaining informed consent, which is really how we act out as professionals, the practices of autonomy, we have to make sure that consent is being given voluntarily. The second is the notion of capacity. A person has to have the ability to understand. And so we can see that the very young, people with dementia, people who are severely mentally challenged or mentally ill, may lack the capacity, or their capacity may be limited or absent. And this can change over time. So capacity also needs to be understood as something that evolves and that is dynamic. And also, people have capacity perhaps to make decisions in some parts of their lives and not in others. So we need to be very attuned to this notion of capacity. And whenever possible, if a person has the capacity to make a decision, he or she should be making it. And the last dimension for us to consider in terms of informed consent is comprehension. And this is the actual understanding. So a person may lack capacity because of a lack of comprehension. So this can be from issues of language, not being able to understand English, or being able to understand the technicalities of the physical body or the treatment that's about to be offered. So people have to actually be able to understand it for them to give informed consent. The related concepts to this, as shown in the bubble diagram, are these notions of honesty, trust, and power. So from the little segments of the WIT video, if you recall in the opening chapter where she's giving consent, we actually challenged some of that in our weekly discussions. And we probably observe these practices all the time, where we use the power structures, we use complex language, we use inducements as ways to try to have people make decisions that align with what we would want them to decide. And so it really calls upon us to use virtue ethics and to really think about trust and power and honesty. An area that is quite interesting to consider as well is that nurses do not have to approve a patient's decision. And I think in some ways, if we can internalize this idea, it can actually make our work a little bit easier. Really, people are making the decisions that are best for their life, and we need to recognize that health is uniquely lived, and the decisions of one will not be the decisions of another. So even when we don't approve a patient's decision, we still cannot abandon a patient. We must really respect and honor that is that person's will. And in this, again, we need to be aware of power relations and how these are being enacted. So I just said that nurses cannot abandon a patient even if they don't agree with the decision that the patient is making. And the other side of that, or one of the other sides I should say, is that we also have to be alert to instances where somebody's autonomy is influenced by values, beliefs, or cultures. So in some instances, people do not make their own decisions. In fact, those might be done in community. It might be done by the head of the household. It might be decisions may be made by a husband, even when the person is competent to make his or her own decisions. So it can be quite difficult when we see these practices that from our viewpoint may not actually be autonomous practices. And those can create tensions and disjunctures within our practice when we see patients living out beliefs and values in ways that don't necessarily align with our views. Another one of the bubbles from our overview diagram is this idea of assent. This idea of assent meaning agreement. So even when a decision has been made by a substitute decision maker or the patient him or herself, the nurse really must ensure that the patient is assenting to the procedure. So what do we do when a patient dissents? I think there's a really interesting situation on page 142 and to 144 about situations with sick children. Okay, we're going to switch gears for a moment and talk about some of the practicalities in terms of informed consent. One of the key areas of consideration that helps with us understanding this notion of informed consent, remembering that we have informed consent as a process and we consider it as an ongoing process so that we can ensure that a person's autonomy is respected and maintained, so that we can ensure that people are actually free to make decisions in terms of what happens to their bodies. And earlier in this week, we discussed about some of the limits to autonomy. But for these discussions, I'd really ask you to think about informed consent as an ongoing process. So patients have the right to receive information, and they can either consent or refuse treatment or delay decisions. People can agree to something and they can change their minds, and that's a part of this ongoing process. So even if somebody consents to have surgery, just before the anesthetic is given, they can still withdraw consent, and that is something that we need to be aware of and we need to respect. But as the readings for this week and in previous readings have highlighted us to the notion that the way that we give information, how much information we give, in what style we give that information, and how much we pay attention to health literacy can inform this consent process. So providing too much information can also be seen as negligent, and providing too little can also be seen as negligent. So we can see that sometimes we use patient teaching as a way to limit autonomy, and you've been asked in this course to give consideration to the way that you use patient teaching strategies. So because no patient can really be fully informed, we sometimes wonder, is informed consent even possible? So the legal standard for informed consent is to provide adequate information. And remembering our class where we discussed the law, often the ideas of adequate come from what a nurse would do in the same situation or a similar situation. So our practice is really measured against that of our colleagues because we're self-regulated, and that's the way that our legal system works. So our challenge really is to determine adequacy. And as you can imagine, that is very context-based, and it's very individual-based. However, there are standards, and there needs to be self-awareness and self-knowledge in terms of how you're considering adequate and how you're using the strategies of patient teaching. So a little bit more help in terms of how much is adequate. We do have the Healthcare Consent Act, and it says that information that a person in the patient's particular situation would need to know in order to make a decision. So we can see that not only are we measured against what a nurse would do in a similar situation, we also need to think of what would a person need in a particular situation in order to make a decision. So we do have a little bit of help as professionals in terms of understanding how much is adequate. And some of this guidance comes from the Healthcare Consent Act again. So in terms of giving information for informed consent, people have the right to understand the problem. They have the right to have enough information to understand what is happening to their body. The other area is that patients have the right to understand the treatment and also to know if there are other reasonable options. This is one of the ways that health teaching is used in a coercive manner. If only one or two options are presented, when in fact there are 3 or 4 options, that's not really viewed as giving adequate information to make informed consent. However, there's also the reasonable option, as it's described. There isn't an obligation necessarily to present every possible option, but the reasonable options. Patients also have the right to know the consequences of delaying or of not treating. And this is important because often, for our sake and our sense of efficiency and effectiveness, we would like patients to make decisions right away so that we can get on with it. However, patients have the right to know about the consequences of delaying that decision. And there are many instances where the decision does not have to be made right then and there. And letting patients know if there are little or minimal risks to delaying, that sometimes can help them move through the information and make a more autonomous decision. Patients also have the right to understand the expected benefits and risks of the treatment proposed, also the expected benefits and risks if they receive no treatment, or the benefits or risks of the other options. So really, we have to provide enough information so that people can make an informed decision. People need to know the effects and the side effects of treatments and the consequences of not treating. Any question that a patient poses to us, we are supposed to answer or find somebody who can answer it. So these guidelines start to define a little bit more for us about how much is adequate information. So what does this mean in terms of the real day-to-day work and everyday work and every night work of a nurse? Is that we need to individualize our care by asking patients about their specific situation and about their concerns. So we can't give a pat spiel and think that that would be adequate for that person. We have to provide information in language the patient can understand, and if this requires getting a health translator, then that is what's required. Here as well, we need to pay very specific attention to health literacy. And in Health and Healing 1, this is going way back, we had a whole class looking at patient teaching and health literacy. So we need to recognize that not everyone has the vocabulary, the literacy, or the numeracy skills to understand what's being explained. And we have to find different ways of saying the same thing until the person understands. One of the strategies that we can use is have patients describe the procedure and its risks and benefits back to us. And we can provide written information concerning the treatment, but we also need to be responsible in terms of what we hand people, and when we're involved in producing these documents, that we pay attention to health literacy principles. So in terms of other practice implications, we need to be available to the patient for his or her questions, and we need to give the patient time to consider options. As I mentioned, people have the right to know if a delay in making a decision has little or minimal risk, and so if it's possible, we need to give patients time. If a patient asks for a second opinion, they have that right, and we need to facilitate that. And we need to document the discussions that we have with patients concerning informed consent, because it really is the documentation process that helps to protect us legally to ensure that we've followed a good process. So I'm just going to end this segment on substitute decision makers. So when people are not able to make their own decisions, there's some issue with capacity comprehension, is particularly when we bring in a substitute decision maker. So the next 7 slides are based on a presentation that I attended by Sarah Chetner. She is the lawyer for the Ontario Public Guardian and Trustee. And this presentation was made just about a year ago. So when we find ourselves in situations when working in the healthcare system that a patient cannot make his or her own decision and a substitute decision maker has not been named, or there isn't somebody who fits the criteria that I'll describe in a couple of slides from now, the Office of the Public Guardian and Trustee can be called. The Public Guardian and Trustee is in fact the last resort for substitute decision makers under the Healthcare Consent Act. So we would only use the Public Guardian and Trustee when there is no one else to make decisions. It's also used if equally ranked substitute decision makers disagree. So sometimes we will call in the Office of the Public Guardian and Trustee to help reconcile a difference. The Public Guardian and Trustee do use recommendations from frontline staff on end-of-life decisions, and they make recommendations to senior management. So this is really last resort measures that are used. So based on current law, who can be a substitute decision maker? So someone can be a substitute decision maker if the person is capable and can understand information and can appreciate reasonably foreseeable consequences. So a person must have capacity and comprehension. A person must be available, and the person must be willing to assume responsibility. So just because somebody names you as their substitute decision maker, if you're not willing to assume that responsibility, you are not obligated to fulfill it. There's also a ranking in terms of who is first in line for making a decision. So this is how the ranking unfolds, and it's very important for you to pay attention to some of these ideas in practice. Sometimes within the healthcare setting, people will come in and they will say, I am so-and-so's substitute decision maker. You are actually required to see proof of that. In some instances, people come in and they don't actually have documented proof that they're the substitute decision maker, and that actually puts your practice under a little bit of threat. So you do have the right to ask, can I please see the signed document that you're the substitute decision maker? Typically what you will see is that one person will ask for proof, and then that gets photocopied and put on the patient's chart so that everyone doesn't need to be asking the same question. So in terms of ranking then, anybody who is appointed as a substitute decision maker is first. So this is somebody that through a lawyer's office or through some kind of a document has been appointed by the patient, him or herself, to be their substitute decision maker in the event that they become unable to make their own decisions. So that's an appointed substitute decision maker. It's somebody, another word for it is attorney for personal care. And there can also be board-appointed representatives for substitute decision making. So if somebody doesn't have an appointed substitute decision maker, they would use a statutory substitute decision maker, and it falls in this order. So first line would be the spouse or the partner of the patient, if there is one. If there isn't a spouse or a partner who is willing and able to be the substitute decision maker, you have to go back and forth between this slide and the previous one. So if somebody does not have a spouse or a partner, then the child or the parent would be the next in line. Again, ensuring that they're capable and that they want to assume the role and that they're present. So if there's neither a spouse nor a partner, a child or a parent, then a sibling is the next in line. And then after that, any other relative through blood, marriage, or adoption. So that is the order in which the statutory substitute decision makers are ranked. And so it's important for us as nurses and to be working with the interdisciplinary team and with administration to ensure that we are using this ranking of decision makers. So when do we use a substitute decision maker? As I said a few moments ago, we only use a substitute decision maker when the person is not able to make their own decisions. So it's important that you go back to those slides to understand what is required for somebody to make their own decisions, and to remember that while somebody might not be able to make decisions in one area, they can in another. And that is acceptable. So we only use the substitute decision maker when someone is not mentally capable of making one or more decisions about his or her care. It's also best to resolve the issue of who is the substitute decision maker sooner rather than later. So we can often foresee that ethical situations are going to arise and that a person's condition may change or deteriorate and lessen their ability to make their own decisions. This is in the whole realm of preventative ethics that we discussed earlier in the course. So we know that if somebody is on a health trajectory, that their situation will decline. And so long before it declines, we should be really clarifying these issues of who is the SDM. One of the other places where we can use the substitute decision maker is for information and clarification around the patient's values and wishes and trying to understand the patient and their situation. And as I mentioned earlier, the substitute decision maker, especially if it's an appointed one, really should be asked for proof. So we go back and forth to looking at who is the SDM. So if it is the spouse of a person, the spouse or a partner of a person, we know that they're the number one ranking. And if somebody is declaring that they're the SDM and they're also the spouse or the partner, then there's consistency with that. But we do need to be very careful, as I mentioned, that we aren't letting somebody make decisions, assuming that they're the substitute decision maker, only to learn the next day that in fact there was somebody who had been appointed. So what does the substitute decision maker do? Well, they actually consent to or refuse treatment proposals. They decide on a treatment plan, and they make these decisions with the healthcare providers just as the patient would do. So these decisions can include administering, providing, or withdrawing treatment. So they make decisions similarly to what the patient would be making decisions on. So substitute decision makers actually have rules to follow. And it's quite interesting to know that the substitute decision maker is not making decisions based on what the substitute decision maker would want, but they're in fact making decisions in the best interest of the patient. And where they know it, they have to use the expressed wishes of the patient. So they're really there to ensure that the decisions that are made are in keeping with what they know about that person and what that person has told them in terms of their end-of-life wishes, for example. So the substitute decision maker has to make decisions in the patient's best interest while considering the patient's values, beliefs, and current wishes. So it's quite a big responsibility, because sometimes substitute decision makers are called upon to make decisions that he or she would not make for herself or himself. They're actually making decisions based on the patient's values, beliefs, and wishes. And there are 4 factors on the next slide that further guide the substitute decision maker. So these 4 factors continue to guide the substitute decision maker. They must ask themselves, is the treatment likely to improve the condition or well-being, prevent deterioration, or reduce the extent or rate of deterioration? The substitute decision maker needs to also consider whether the condition or well-being is likely to improve, remain the same, or deteriorate without the treatment. And does potential benefit to treatment outweigh potential risk of harm? And does a less restrictive, intrusive alternative treatment offer as much potential benefit? So many of these 4 factors are similar to the kinds of information that the individual would use for decision making. But for the substitute decision maker, they need to be answering these questions in terms of the patient's values, beliefs, and expressed wishes. Okay, so this concludes the Week 8 presentation around autonomy and informed decision making. We've covered in a very brief way some very significant and important topics for ethical practice. It's important to remember that autonomy is the foundational feature for ethical practice and for ethical decision making. In our short time together, we've had an opportunity to explore some of the constraints to autonomy, some of the strategies that promote autonomy, and some of the ideal goals. We've talked about some of the ethics theories and approaches that support autonomy and that limit autonomy. We've explored professional practice and institutional organization of care that can both hinder and promote autonomy. We've also looked at some of the legal systems in terms of who decides, how consent is achieved, and how consent is a dynamic process. We've specifically examined some of the current understanding of substitute decision makers, because this is an area that we encounter in practice that sometimes makes us a bit nervous when patients aren't making their own decisions. However, we've only touched on these topics, and there still is a lot to learn. So I would encourage you to work through the case study, either using a situation from your own practice or from the presentation of the WIT chapters. And there are also 2 articles that were required for this week. And so there are 2 forum discussions that you can please join, at least one of them, and we can continue exploring this important topic of autonomy and decision making.